Hi everyone, welcome to today's LACNETS webinar, Focus on Immunotherapy and High-Grade NETs. I'm Lindsay Judovine, the Director of Communications for LACNETS, and this is...
I'm Lisa Yen, I'm the Program Director for LACNETS.
Before we get started, I'd like to thank Rich at TVP Live for making today's webinar and high-quality production possible. You're the best, Rich. We will be having a live Q&A following today's presentation. So to submit your non-case specific questions for today's speaker, go to www.slido.com and enter event code LACNETS. That's LACNETS. Before we get started, here are a few tech tips for today's webinar. As a reminder, for your audio, be sure to turn the volume all the way up on your computer. Also, please double check that the volume is unmuted on the webinar broadcast screen. For the video, you can enlarge the webinar broadcast screen by clicking the Expand Screen button in the bottom right corner. Also, the full webinar will be posted on the LACNETS YouTube channel within the next few days. You can also check out our YouTube channel, which has a video library of 100+ net videos. And be sure you're following LACNETS on social media. We're on Facebook, Twitter, and Instagram with the handle @LACNETS. As a reminder, these webinars are done for educational purposes only and not suitable for medical advice. Please talk to your medical team if you have any questions or concerns about your individual care or treatment. We all have our own opinions, and these are our own opinions. They do not necessarily represent the opinions of LACNETS. And now I pass it off to Lisa to give a brief history of LACNETS and introduce today's speaker. Off to you, Lisa.
Thank you, Lindsay. As you may already know, LACNETS stands for the Los Angeles Carcinoid Neuroendocrine Tumor Society. Our mission is to provide education, advocacy, and support for all people impacted by this rare disease that used to be known as carcinoid, an old term meaning cancer-like. The more accurate term is neuroendocrine tumor, or NET for short. You'll often hear us say neuroendocrine cancer since we know that this is in fact a type of cancer. In the medical professional world, they also use the term neuroendocrine neoplasm, since neoplasm is the medical word for cancer. While you often see Lindsay and I leading the meetings and programs, we're led by a team that includes our interim administrator and board member, Kavya Velikapudi, board member Donna Gavin, also the sister of LACNETS founder and executive director emeritus Giovanna Joyce Mbasi. Our newest board member is Mary Dunleavy, who you may remember hearing her talk about scanxiety at our recent June 2020 LACNETS annual conference. And also in November on our Cancer Day Symposium, she spoke about being on a clinical trial. In addition to our board of directors, we are grateful for the counsel of our advisory board. As you may already know, LACNETS was founded in 2012 by jazz musician and composer Giovanna Joyce Mbasi, who was a NET patient herself. Giovanna was diagnosed in 2005 with metastatic small bowel neuroendocrine cancer. She then pursued her MBA for the sole intent and purpose of launching a NET patient advocacy group in Los Angeles. She lived fully with her diagnosis for 14 years until succumbing to her disease approximately 1 year ago in November 2019. On her last day on this side of heaven, Giovanna said to me with great pride that she felt her greatest legacy was founding and building LACNETS, now one of the largest NET patient advocacy groups in the country. Our NET hero left behind a legacy and a vision. Her vision was to empower NET patients and caregivers by providing a healing exchange of educational resources and emotional support so that we may learn to live richly and fully. To this end, we have launched the Vision Initiative. We launched this in November because November is a special month, while we remember and honor Giovanna on the 1-year anniversary of her passing. We also know that November 10th is World NET Cancer Awareness Day, a global initiative to spread awareness about NETs. NET Cancer Day was also special to Giovanna because Giovanna's birthday is November 9th, the day before NET Cancer Day. So while we are remembering Giovanna with the 1-year anniversary of her passing, this is also a celebration of her life. Giovanna liked to say, aging is a privilege, and this perspective and gratitude comes from a really special place. To the general public, many people may have only heard of NET because of celebrities such as Steve Jobs and Aretha Franklin, who sadly passed away from the disease. But our hope is to change the narrative from associating this disease with famous people who sadly passed away from the disease to growing awareness of the more than 180,000 people living with the disease. And we want to support you as you learn to adapt to your new normal and help you live richly and fully despite living with the disease. So we invite you to contribute to Giovanna's vision and help continue what she felt was her greatest legacy, LACNETS. Your gift will be matched 100% up to $50,000 if you contribute by December 31st, 2020. Large or small, every gift matters and is greatly appreciated. If you have benefited from our programs, please consider paying it forward. We invite you to share the word and spread the vision to your family, friends, and community. Today's topic is high-grade neuroendocrine neoplasms. Our speaker is Dr. Neena Vijayvergia. She is the Medical Director of Medical Oncology at Fox Chase Cancer Center in Philadelphia. She is named one of the top physicians under 40 in 2020 by the Pennsylvania Medical Society. Dr. Vijayvergia comes from a family of physicians and wanted to be a doctor for as long as she can remember. She realized early in her training that she wanted to dedicate her career to help discover new therapies for patients with gastrointestinal cancers, with a particular focus on pancreatic and neuroendocrine malignancies. Dr. Vijayvergia has a personal connection with NET as she has a family member who passed away from it at an early age. When I met Dr. Vijayvergia, it was clear to me that she is passionate about neuroendocrine cancer. And she said to me that high-grade neuroendocrine neoplasms has a special place in her heart. We are grateful to welcome Dr. Vijayvergia today to speak on a topic that often doesn't receive enough attention. We will first hear from NET patient Cindy, who shares her story of what it's like to live with high-grade NET. We will then hear from Dr. Vijayvergia, and her presentation is titled Grade 3 Neuroendocrine Neoplasms, an Unsolved Mystery, Immunotherapy and High-Grade NETs. Welcome, NET patient Cindy and Dr. Vijayvergia.
Hi, I am Cindy Poole, and I'm a member of the LACNETS community. Lisa asked me to come and talk to you today because I have been living a pretty active life, even though I have grade 3 neuroendocrine neoplasms. It's been almost 2 years since my diagnosis. I have a small bowel primary with mets to my mesentery lymph nodes, and as my doctor put it, my liver was too full of tumors to count. So that's pretty scary to hear that. The first thing I did was allow myself some time to mourn, and I didn't let myself do that for very long. It's important that you get a care team in place. We did the research, my business partner and best friend, and I did the research, found a care team here in Los Angeles that we were very happy with. We also found 2 more groups that we were going to get second and third opinions if needed, and they were not located in California. So we were prepared with that ahead of time before I ever even really got too far into the process. And knowing you have that in place is really, it gives one a sense of comfort. The second thing I did was contact LACNETS. It was so helpful to go to my first LACNETS meeting and meet people who had been living with neuroendocrine tumors for years, and they were so hopeful and lively. And I don't know what I expected, but it was not that. That was wonderful. Being given that hope was the best gift I think I got during the early months of diagnosis. Secondly, my girlfriend called everybody in our business circle and our girlfriend circle and said, no negativity. Here's what Cindy's dealing with, and we're not going to give too much sympathy. We're not going to cry. We're going to be there to cheer her on and to help her through this. And she was adamant about that. And that was an incredible thing for her to do. She did that without my knowledge. One of our girlfriends ratted her out eventually, and it was just wonderful of her to do that for me. So having a friend who can go to bat for you, I think, is really, really important. The positivity that I was surrounded with was incredibly helpful for the whole journey, and continues to be. Secondly, I came up with things I wanted to do, and I made plans to do them. In the last year, I have taken gliding lessons to fly sailplanes. I have gone to Europe and hiked 110 miles around Mont Blanc, which is Europe's highest peak. I hiked 100 miles around Lake Tahoe this summer. Let's see what else. Oh, I've hiked all over in Nevada, in Utah, all over Southern California, especially in the San Gabriels. So I've been extremely active, and you can do it. It's not easy. You do have to do a little bit of extra preparation if you want to do outdoorsy things like I do. But the point is, you find what you're passionate about and make plans to do them. Stop putting them off. Live for today. That was what my brother and mentor and cancer survivor counselor brother told me to do. Live for today. Make today your best day. And I try to do that. I'm not always successful, but I think I get it right more often than not. Having something to look forward to is immensely helpful. Plan a dinner with girlfriends, or for me it's hiking, especially during COVID when I can't have that dinner with girlfriends. Getting out in nature has really helped me. Even if you can't hike long distances and you have issues where you're really not comfortable going out, you can still drive into the mountains. There's precautions you can take. There are things you can do. Get out, enjoy life, I think, is the most important thing and important message that I could give to anybody. There is hope, and you can still go and enjoy life. If you have questions, how do you deal with carcinoid syndrome symptoms? Ask on LACNETS, ask on the Facebook forums, and you're going to get some positive answers. So yeah, be on the lookout for hope. Find it, create it. Get out there and live your best life every single day. This is like a game of whack-a-mole. When things pop up, you deal with it, plan the next thing that you're going to enjoy, and move on. Tomorrow I have bland embolization on my liver. 3rd time this year, and yet I've still been able to go and hike and do all the things that I wanted to do. I'm not letting that procedure get me down because it's just whacking the mole. Get out there, live life to your fullest every day. Follow me I have an Instagram where I put some of my adventures out there for others to see. Some of it's a trip to the hospital, some of it's a trip to the mountains. So follow me at Zebra Hiking on Instagram. Take care.
Hello, everybody. Thank you so much for the kind introduction, Lisa. And I'm here to talk a little about what G3 neuroendocrine neoplasms are all about. And so let's dive into it right away. So my name is Neena Vijayvergia. I do GI oncology and focus on neuroendocrine tumors at Fox Chase Cancer Center in Philadelphia. And high-grade neuroendocrine tumors and carcinomas are an area of special interest for me. So we'll talk all about them today. So here are my disclosures, as you can see. While we do this talk, the few things that we're going to talk about are a little bit about the definition and background of these kinds of tumors, a little bit about the nomenclature because it gets really confusing even to oncologists. We're going to talk about how their outcomes are and how they change over time. We're going to talk some about the treatment options with the focus on immunotherapy and some newer options that are out there. And then a little bit about some future directions, which is focusing a little bit about the kind of work that we have done at our institution. So how do we define G3 neuroendocrine neoplasms? So what they are, the full form is grade 3 neuroendocrine neoplasms, and in short, we call them the G3 NENs. They cover like a full grade of tumors, which are the high grade neuroendocrine cancers, and typically are divided into two parts: the NET G3, which is grade 3 neuroendocrine tumors, or the NEC, which is the neuroendocrine carcinomas. The G3 NENs and the NET and the NEC differ from each other in terms of their prognosis, what treatments work better for one versus the other, and also there's differences in terms of where they arise from, what is the rate at which they divide, and even what are the molecular changes in these cancers. So these are very different kinds of cancer that are lumped into this group of high-grade neuroendocrine neoplasms. The next slide here just shows us why studying about neuroendocrine neoplasms is so important. As you can see by the orange line here, the incidence of neuroendocrine neoplasms is growing by leaps and bounds. It's grown by 7-fold, or 6.4 to be precise fold, over the past 40 years, whereas the overall cancer incidence has stayed pretty similar during that time. Some of it is because of better diagnostic techniques, more imaging, more colonoscopies, and low-dose CT scans of the lungs for the lung tumors. But nonetheless, we're seeing them more, so we need to invest our energy to them. If we look at the high-grade neuroendocrine neoplasms, they form a very small fraction of overall the neuroendocrine tumor diagnosis. Why it is important to know which type of neuroendocrine neoplasm it is it low grade, is it high grade, is because the grade of the tumor affects how well the patient does with this disease. So prognosis is affected by the grade. As you can see in this graph here, the bars, the histograph bars for the high-grade neuroendocrine tumors, which is the ones that I'm pointing here, really are very, very small compared to, as you can see, for the low-grade tumors. And what this is depicting is how long people live. So the median survival, or median OS, is how long people live with that condition. And you can see the grade 3 or higher tumors, they tend to do much worse. But even in them, if you have appendix grade 3, you tend to do slightly better than if you had it in your large intestines or liver. So it's very important to know that the grade of the tumor affects the outcomes. Hence, it's very important to know that, because the treatment is defined by that. The next slide here talks mainly about high-grade or grade 3 neuroendocrine neoplasms. So this was a SEER database analysis of patients with grade 3 neuroendocrine neoplasms. And here, as you can see, most of these tumors arise in the lung. So if you see, the incidence of high-grade neuroendocrine neoplasms is about 8 or 9, even some studies for 100,000 population. But if you just look at the lung, 8 out of those 9 are actually lung neuroendocrine neoplasms of high grade. A very small fraction of them are extrapulmonary, or outside the lung, and these are mainly the GI tract, as you can see here, about 3% of them. And then some are unknown, and most of the unknowns are GI. And then there are other sites like prostate, the cervix, and these areas where we see some of these high-grade neoplasms. And you can see here the GI neuroendocrine neoplasms, they tend to be more of the large cell variety, whereas those in the lung tend to be more of the small cell variety. And that's just how these tumors look under a microscope. And we'll talk a little bit more about them as we go on. So now we come to the nomenclature. So it took the medical community a long time to finally come up with a more robust way to define these tumors. You can call it different terms. You may hear G3, high grade, poorly differentiated, NETs, NEC, NENs, and these are just different terms we use. So we had to standardize it. As you can see here, this report card could become carbon tetrafluoride too. So in this graph here, what it mainly suggesting is that neuroendocrine tumors are typically a term reserved for the typical cancers that we see, which still maintain their features under the microscope like neuroendocrine cells do, and the rate of growth is not very high. As you can see here, the NET world is mainly grade 1 and grade 2. Compared to it, the neuroendocrine carcinomas are a group of cancers that are poorly differentiated. So when you look under the microscope, they don't resemble the low grade or the well differentiated NETs just on morphology. And when you look at the rate of their growth or their proliferative index, that's really high. That's the Ki67 score, and it ranges 80, 90, 100%. But these things are not exclusive of each other. As you can see here, there is an overlap. So some of the poorly differentiated carcinomas are sort of towards the lower rate of Ki67, so they are not as proliferative. Compared to it, there are some NETs or neuroendocrine tumors that have still, well differentiated histology, but the rate of their growth is higher, and their Ki67 is greater than the 20% magic number that we use to differentiate low grade and high grades. So you can see this when, this is the circle, which just suggests an overlap between the two. And that's where a lot of conundrum happens. Like, are these tumors NETs? Are these tumors neuroendocrine carcinomas and things like that? Interestingly, how we differentiate them is how they look under the microscope, right? So when you look under the microscope, do they look anything like normal neuroendocrine cells or are well differentiated, or are they very de-differentiated or poorly differentiated? And to do that, you need a pathologist to look at them. There's no objective test that can look for it. And interestingly, NET pathologists cannot even agree as to a lot of times as to whether this is a NET or a NEC, which suggests that there's area for improvement in the diagnostic technologies. So in one study, when pathologists were asked to review the slides for patients with G3 tumors, either NET or NEC, only about 61% of the time, they didn't even agree that somebody called them NEC and the other one calls them NET. And it's very important to know that, because as we move along, you will see that there is difference in how these patients do in the long term. So apart from just looking at the microscope, there's also some molecular differences between these cancers that we've identified over time. So as you can see, a small cell cancer, they have very small cell with round red, blue nuclei, as you can see here. These are the small cell neuroendocrine carcinomas. They don't look like well differentiated cells, or they don't make any specific pattern. They're just sheaths of cells. And they have very specific mutations like the P53 and RB. Then we have the large cell neuroendocrine carcinomas. They still have sheaths of cancers, but the cells are not so small, and their nucleus are not so packed as you can see here, comparing to the small cell cancers. Again, they have P53 RB mutations, and there's a KRAS mutation we see in them too. Compared to that, the neuroendocrine tumors, you can see a stark difference. They look like normal cells. I'm sure it's hard to imagine what normal cells would look like, but they look well behaved, if you can imagine that for me once. And those tumors are neuroendocrine tumors. They may be, have a high proliferative index, but still they maintain their well differentiated form. And when you look at, when you do molecular testing, they tend to have mutations that are seen with the low grade tumors like DAX, ATRX, MEN1, and mTOR. Now, there are molecular differences, but there's also clinical differences between these, the NETs and the NECs, as we call them. So one of the largest series of how patients with G3 tumors, so G3 is the common term for all high-grade neuroendocrine neoplasms if their proliferative index is greater than 20%. And in those patients, if you look and divide them based on their score, the score can range from 20 to 100%, but patients who have a Ki67 less than 55% versus those who have greater than 55%, there is a clear difference between these two cancers. And we typically think that's because most of the well-differentiated neuroendocrine tumors fall in the category where the Ki67 is less than 55%. And you can see here in this table, ORR means response rate to treatment. So they looked at how these patients did when they were treated with the standard treatment options or chemotherapy that we use for the grade 3 patients. And that is a drug called carboplatin or cisplatin, and we add another drug called etoposide. So it's platinum-based chemotherapy is the fancy term for it. And when they looked at patients who were high-grade tumors, so they had a higher proliferation index greater than 55%, their tumor shrank more with this chemotherapy compared to those who had a Ki67 less than 55%. So 42% of the patient had shrinkage in tumors if you have high Ki67, whereas only 15% did if you have low Ki67. When they looked at how much time it took for the cancers to grow, so progression-free survival, or how much time these patients lived, definitely the patients, the progression-free survival between the two arms wasn't any different. So that means getting the platinum-based therapy didn't matter whether, how long you lived in terms of progression of disease, but it really mattered that patients who were lower Ki67 tended to live longer. So they had 14 months survival compared to 10 months if your score was greater than 55%. So now we have molecular evidence that these tumors might be different based on having different mutations. Now we have clinical evidence that patients with the lower Ki67, where the net G3 lie, tend to live longer and don't respond as well to platinum-based chemotherapy. So based on all these data and many other studies, I just pointed out the two seminal papers, but a lot of other studies presented similar results. And based on this data, in 2019, all GI high-grade neuroendocrine tumors or neoplasms were reclassified. So now how we define them is that we call them into two big buckets: well-differentiated neuroendocrine tumors or poorly differentiated neuroendocrine carcinomas. The well-differentiated neuroendocrine tumors, if you look at the microscope, they appear well-differentiated, and then you see how many cells are dividing at any given time using the Ki67 score stain. And that can be less than 3%, which is grade 1, 3 to 20%, which is grade 2, or greater than 20%, which is grade 3. So the net G3 is the well-differentiated neuroendocrine tumor with the Ki67 score greater than 20%. Compared to it, the poorly differentiated neuroendocrine carcinomas universally have a Ki67 greater than 20%, but when you look under the microscope, they're also poorly differentiated, like sheets of cells rather than forming any patterns. So this is a new classification. All of these fall in under the bigger umbrella of neuroendocrine neoplasms or NENs, and then you have the NETs, which are well differentiated, versus NECs or neuroendocrine carcinomas, which are poorly differentiated. Now, this is a way how the G3 NENs can be classified, and it basically just suggests what I was just telling you, that the NENs addresses everything. If you're NET, you are well differentiated. If you're NEC, you are poorly differentiated. And there's also this concept of mixed neuroendocrine neoplasms, where you see cancers of the gland-forming component, which is the adenocarcinoma, and also the neuroendocrine cancer. They're like mixed in together, but each of them is greater than 30% of the cancer cells. Those cancers are typically treated like adenocarcinoma, so we wouldn't talk about them more today. Now, what are the differences? Clinically, yes, I found out whether you're a NET or a NEC. I talked about some differences in terms of the molecular features and in terms of how they do and what their prognosis and response to treatment is. But this table points out some other important differences. I do, for the sake of my audience, the things I really want to focus on, the primary tumor locations. The G3 NET are much more common in the pancreas. About 50 to 60% of them occur, their primary tumor occurs in the pancreas, and then it can spread to other places. Whereas in NEC, only 25% of them are in the pancreas. Also, the NET G3, because they're more like the low-grade tumors, they tend to have positive receptors for the somatostatin analogs or octreotide. So when you do the gallium-68 dotatate scan, or the NET spot scan, as I would call it, those tumors light up. That's about 88 to 90%. It is not that common with the NEC or the neuroendocrine carcinomas. The PET scan, which is the run-of-the-mill PET scan, the FDG PET scan we use for all other types of cancers, not the neuroendocrine cancers, those are much more highly positive in the neuroendocrine carcinoma world, not so much in the NET G3. And then we talked about the response to platinum drugs, and we talked about their survival as well already. So these are some important differences between the two. That's why it's important to distinguish. And the reason why I'm honing on this is it's a new concept. Sometimes, a lot of pathologists don't know about it. So if someone's diagnosed with them, it's very important to find out if they're G3 neuroendocrine neoplasms, are they the NET G3 or they are the neuroendocrine carcinomas, because the treatments will differ as we talk about a little bit more. So one important question that comes up is this a continuum? So somebody got diagnosed with a grade 1 neuroendocrine tumor in their pancreas or their intestine somewhere. Can that become a neuroendocrine carcinoma or a NET G3 down the line? So we know from studies that G1 and the G2, so the low-grade neuroendocrine tumors and the intermediate-grade neuroendocrine tumors, as they progress and as they metastasize, as time moves on, some of them can degenerate into a higher grade. They can become NET G3s. The poorly differentiated neuroendocrine carcinomas are rarely a result of progression from grade 1 and grade 2, but likely a completely different disease entity. They have different mutations that cause them, and they're probably not a continuum or progression of the same disease. There have been studies that have been done which shows that poorly differentiated neuroendocrine carcinomas are rarely seen to coexist with the low-grade tumors, which further confirms what we are talking about here. Now let's talk a little bit about outcomes and survival for this disease. It's unfortunately not as good survivals as we see with the grade 1 and grade 2 tumors. But if you just look at the median survival for the poorly differentiated neuroendocrine carcinomas, so these are like the poorly differentiated tumors with a high Ki-67. In the neuroendocrine carcinomas, the table here suggests how well they do. This axis here is the number of months that their overall survival is. That's median survival, which is like the 50% number. And these are in the lower side, you see all the different sites of disease. Now, as you can see, if you find it early and it's localized, patients tend to do better, right? They have good survival. And the asterisks just mean that, they're surviving past that 5-year mark or 60 months. Unfortunately, once you develop metastatic disease or the cancer comes back, the survivals are not as good. You can see 5 months, 6 months, 11 months, 2 months, 5 months, 7 months. So all in the range of 6 to 12 months, but their survival remains if you have metastatic disease. So it's a much more aggressive cancer. Now, compared to that, if you look at the NET G3, there are multiple studies. It's a newer concept. We don't have as good data with a lot of patients over time, but a lot of smaller studies that some of them I've mentioned here have suggested that even in advanced stage, if you are a NET G3, the average survival or the median survival, it's not the same thing, but where the 50% number lies, you could say, ranges anywhere from 43 to 99 months in different studies. So, compared to what I was talking about, 6 months, 12 months, here I'm talking about 3 years to 7 years to 8 years down the line, patients are still alive with NET G3. So it's a completely different disease entity. Now let's talk a little bit about what treatment options are available for these cancers. So, we just talked about the fact that the NET G3, this was a very nice figure that was presented in one of the journals and one of the articles by Dr. Sorbet. This is suggesting that as the proliferative index goes up, right? So as you see more cells are dividing at any given time, the survival shortens. And as you go towards that direction, as the proliferative index increases, your avidity on the NET spot scan or the somatostatin receptor imaging, as we call it, goes down, and the PET scan, the regular FDG PET scan avidity goes up. When you look at the differentiation, most of the well-differentiated G3 NETs fall into the category of the lower end of the spectrum, less Ki-67, have positive somatostatin receptor, compared to the poorly differentiated tumor fall towards the right side of the spectrum, which is higher Ki-67 and higher proliferative index, and they have FDG positivity. And as you can see here, in the lower grade tumors, the biologic therapy, so a lot of the drugs that we use for the low grade tumors or the G1 and G2 tumors are effective. PRRT, or peptide receptor radiotherapy, which is a new kid on the block, and we'll talk about that, is definitely may be effective, especially because they have the somatostatin receptor imaging positivity. Whereas as you move towards the higher grade and the higher Ki-67, what works best is chemotherapy. So chemotherapy is utilized for patients with higher grade tumors. For lower grade tumors, we tend to use drugs that are similar to the NET, the G1 and the G2 NETs. And also in between somewhere, we use alkylating based chemotherapy, which is the temozolomide and capecitabine. These are oral chemotherapy drug combination that we use very often for patients with NET G3 and the lower Ki-67 NETs. So this is just a figure explaining in one word how we define and how this is a continuum with which, and the idea is how we treat these patients. So this is a study where we published a framework of how we can treat patients. So the NET G3 patients are typically treated according to the paradigm that we have for the G1 and the G2 neuroendocrine neoplasms. Now we typically, these, just reading through different somatostatin analogs, which is your sandostatin and lanreotide or somatulin, come into play. And then these are all the different other agents that are used. Now, interestingly, because the NET G3 are slightly more aggressive than just your G1 and G2 tumors, we tend to utilize chemotherapy, which is the capecitabine and temozolomide, very often and early on. We tend to use somatostatin analogs by itself less frequently. We do use it in small amount of cases, but not as much. And we know PRRT, if the tumor is receptor positive, is an option, even though it's not studied in this population as well as it is studied in the low-grade tumors. We think that the NET G3 population will likely benefit from this option. And more studies are needed to prove that. But everolimus, doing sunitinib, and liver-directed therapies are definitely options for the NET G3 population. Now, I want to take a second to talk about PRRT. I'm sure most of the people here know what this is, but I'm going to talk about it anyways. So in this slide, this slide just depicts, I took it from the AAA website, but it basically depicts the mechanism of how PRRT works. So what you do is, you inject, basically in the bloodstream, it's a radiation particle, which is a beta emitter. What you do is you attach it to octreotide and you give it intravenously to the patient. And then what happens, because of the octreotide, it goes and attaches to the tumor cells. And then once it's attached to tumor cells, the radiation particles are internalized, as you can see in this picture. And then the radiation causes damage to the cancer cells. And then the cancer cell dies, and lo and behold, we get benefit in terms of decreased rate of growth, also shrinkage. About 18% of the time there's also shrinkage, especially in the low-grade tumors. So this mechanism of action was very exciting. Based on this, there was a study that was done in, as you can see here, in low-grade tumors, where we saw that the progression-free survival, or the time it took for the cancer to grow again, was significantly reduced. The time it went down significantly, 79% reduction in the risk of death or cancer progression if this therapy was utilized in patients whose tumors express this receptor, the somatostatin receptor. How do you look for that receptor? Is you do the NET spot or the somatostatin receptor imaging. Old times we used to do octreoscan scan for that too. Now, it's approved therapy for low-grade tumors, but let's look at what is the benefit of this regimen in the NET G3 population or the G3 population. So, this is a slide that shows that this therapy might be effective in G3 patients because about 87, 75, 92, so a big chunk of the NET G3 population have that receptor, the somatostatin receptor on their surface, to which this drug is going to go and bind. And that we check through the NET spot or the gallium-68 dotatate scans. So you can see here, so we think this would be an effective therapy for these patients. So then this slide is suggesting, it's a very busy slide, but what I'm trying to show is there are some studies, and this N is basically number of patients in this study. So the largest study had about 149 patients. These were all retrospective studies. So basically patients with G3 neuroendocrine neoplasms were given PRRT, and then we down the line went back and looked at how these patients did. And as you can see, most of them in the pancreas. Now, RR is the response rate. So how many times did we see actual shrinkage in the cancers? As you can see here, that's pretty good. About 35 to 40% of the times the cancers for patients shrunk with this therapy. Now, when you look at, yes, they shrunk, but was it effective? Did they remain, controlled, and did the cancer not grow? And when they looked at that, in the patients where the Ki-67 score was less than 55%, so more of the net G3 type, or there the progression-free survival was anywhere between 12 to 16 months, which means that their patients took this treatment and then for 12 to 16 months after, there was no growth in the cancers. And when we looked at how long these patients did, how long these patients lived, you see that 46 months, 22 months, 31 months. So these patients lived a long time, especially in the lower Ki-67 group. Now, mind you, the lower Ki-67 group is the net G3. They tend to live longer, but we do think that this treatment is especially beneficial for this patient group. And the study here basically just suggests the same thing. Blue lines are good. You're seeing responses, stable disease, and orange lines are not so good. So, most of these places, you see the blue lines are more than the yellows, which means that overall we think PRRT might be helpful. The problem with these studies is these are retrospective studies. And whenever we have retrospective studies, you always worry that, maybe they had chosen patients that were going to do well and were put on this study because, and you go back and look and you just choose the patients that did better. There's a lot of complications or biases that can occur in retrospective studies. That's why we need prospective data to support the use of this treatment in G3 population. Nonetheless, because there's not a whole lot of treatment options available, this is something that is sometimes offered if insurances approve it, because the study that was approved, that the prospective trial for the study was only for low grade or G1 and G2 patients. So that's something to remember. It's an important treatment option for these patients, which is new. This was actually the largest study we were talking about earlier. In this study, there were 150 patients, all with G3 neuroendocrine neoplasms. Most of them, 85% of them, were the low Ki-67 group, which was less than 55%. 20% of them were actually getting in first line, but most of these patients has had some therapy before and now are going to go on PRRT. And as you can see in this graph here, green is patients with the high grade, like the poorly differentiated tumors, high Ki-67, tend to do not as well. And you can see this is like the 50% number here, somewhere here. You see this, the blue line is the net G3. They tend to do the best. They live the longest. And if you are not net, but you're neuroendocrine carcinoma, but your Ki-67 is on the lower end, you tend to do somewhere in the middle. Now, if you look at shrinkage and stable disease, about 42% of the patient had shrinkage in the tumor. Another 38% had their cancer remain stable and didn't grow. And their overall survival was about 29 months. And the progression-free survival, which is the time it took for the cancer to grow, was about 14 months, which is a very good number for the G3 population. So now let's look at the poorly differentiated neuroendocrine carcinoma. So we talked about the net G3. Most treatments we use is chemotherapy, CAP-TEM, which is used for low-grade tumors. It's very often used there. And then also PRRT is possibly an option, but needs prospective data to support it. And also, we talked about some other things like everolimus, sunitinib, liver-directed therapy, etc. Now, if we look at the neuroendocrine carcinomas or the poorly differentiated ones, unfortunately, there's not a whole lot of treatment options for these patients that are prospectively proven. I think part of that is related to the fact that these are very rare cancers in general. The early stage patients, we do resect them, but they do have a higher risk of the cancer coming back despite taking it out. So we tend to supplement the surgery with some chemotherapy plus minus some radiation to decrease the chances of the cancer coming back. Unfortunately, if the cancer comes back or if the patient is diagnosed when the cancer is spread to other organs, that's advanced stage, and in those situations, the survival is limited And we do a lot of treatment options, but there's not a whole lot of data to support it. We basically take our data from the small cell lung cancer literature because it's much more common. As I told you in the very beginning, if there's 9 per 100,000 patients of high-grade cancers, 8 of them are the lung, and that's where we get most of our data from. And we try to extrapolate it to the GI and other worlds, but if we are learning, that's probably not the best thing to do. So what we use is platinum etoposide, cisplatin or carboplatin plus etoposide. So it's given one every 3 weeks. What you do is you do the platinum drug on day 1, and the etoposide is given on day 1, 2, and 3. But based on how the patient's feeling, we sort of sometimes modify it too. And it's given once every 3 weeks, and then we follow them with scans. There's also some other options. There's irinotecan is another drug we use. As a second-line option, not capecitabine and temozolomide is definitely something we use for these patients. And then, there's also immunotherapy that is being looked into for these cancers. So I don't want to go into much detail of the platinum etoposide because I told you there's not a whole lot of frontline data or prospective data that I can show you for these cancers. They do work. The average survival, with these cancers about 11 to 14 months. Whatever treatment really works well, but it's short-lived. At some point, the cancer starts growing again, and then we have to move on to the next treatment option. But definitely, this is an area of unmet need, and we need to develop more studies. There is a national trial ongoing right now by Dr. Jennifer Eads, and she is trying to evaluate the role of this platinum etoposide versus the capecitabine and temozolomide as a first-line treatment options for all G3 patients, not the G1 and the G2, but the G3 NET and the G3 NEC as well, but they're excluding all small cell cancer patients, and they're comparing if one is better than the other. And studies like these are needed to know how we can best treat our patients. So I'll talk a little bit about immunotherapy for G3 neuroendocrine neoplasms. And as you can see here, I told you earlier that we derive a lot of our ideas and literature from the small cell lung cancer world. And in small cell lung cancer, immunotherapy has developed its niche area or its place based on a lot of studies. So the one study that's more important is the combination of chemotherapy plus immunotherapy with this drug called atezolizumab. In this study, they found that patients who did the chemo with the PD-1 inhibitor or the immunotherapy drug tend to live longer. They have a progression-free survival of 5.2 versus 4.3 months. And overall survival, they live 12 months versus 10 months if we didn't give the immunotherapy. So yeah, small difference, but definitely some, every little bit counts in this disease. And then there are these other studies of single agent PD-1 inhibitor, Keytruda, pembrolizumab, combination ipilimumab and nivolumab or ipi-nivo that are shown benefit in this population. So then we decided to look at, grade 3 neuroendocrine neoplasms outside of the lung to see if this thing benefits our patients. So our group, actually, we published as one of the first studies of studying immunotherapy in this patient population. And what we did was a simple study. We were trying to see if pembrolizumab or single agent PD-1 inhibitor, which is an immunotherapy drug, can show any benefit in terms of shrinkage of tumors for patients with the G3 neuroendocrine neoplasms. We did include both the NET and the NEC, so the G3 neuroendocrine carcinomas, as well as the neuroendocrine tumors into our group, but most of our patients were the neuroendocrine carcinomas. Now, this is how we did the study. Patients, got this drug once every 3 weeks, and then we scanned them once every 9 weeks on the study. The primary endpoint was the rate of shrinkage, so the overall response rate, and then we also had progression-free survival and overall survival as secondary endpoints. As you can see here, unfortunately, the treatment wasn't as effective as I would like it to be. There was only one patient who responded to the treatment, as you can see by the green negative bar here. Most of the patients, some had stable disease with the red bars you see here, but most of the patients, as depicted by the blue bars, unfortunately progressed on that single agent drug. So we found out that single agent PD-1 inhibitor doesn't have a role in this cancer. So as moving forward, we looked at the overall survival, which is about 20 weeks for our patients. We looked at progression-free survival, which is how much time it took for the cancer to grow. It was about 9 weeks. which is around the time when we actually did the scans for these patients. We also looked at, hey, can we test a marker, like, that one patient that responded, what made him respond? Interestingly, we checked for something called the PD-1 score. And that score is, in some studies have shown that it can help predict if you're going to respond to immunotherapy. In our patient, that one patient that did respond, his PD-1 score was 0. That's very interesting, but not really helpful. Other similar studies like ours that have been done, there's a drug called spartalizumab, which is a Novartis drug. There's another drug with pembrolizumab for another study that was done by Mulvey et al. And there's also another PD-1 inhibitor that's called JS001. Out of all these studies, the only one that may have shown some benefit was this JS001, where there was some response rate, about 19%. But some patients were neuroendocrine tumors, some were neuroendocrine carcinomas, 4. So total 2 were half and half each type. There's another study of avelumab in this patient population, again, similar results. So I think the consensus in our, in the medical fraternity is that single agent PD-1 or PD-L1 inhibitors are not effective for the grade 3 population. Then came along this study, which is the DART neuroendocrine cohort. So this was a national study of supported by the the SWOG cooperative group. And what it was trying to do was study a combination of 2 immunotherapy drugs together. The first one was called ipilimumab, and the second one was nivolumab. And what they did was they just took cohorts of rare cancers and gave them these drugs. So then when they looked at the results of each of the cohort, they found interesting results in the neuroendocrine cohort of the rare cancer population. There were about 32 patients that were included, and out of those, 56% or 18 of them had high-grade tumors. This was around the time that we already thought that immunotherapy should be explored. So patients were preferentially being put on these studies to see if there was a benefit of using immunotherapy. Most of these patients, about 47%, were gastrointestinal, and some were lung too. Now, as you can see here, the red denotes the GI population, or the high-grade population, which is in the GI as well. And the blue are the intermediate, and the green are the low-grade. What we found is there were some responses, as you can see here, which is denoted by the negative lines that cross this bar of 35%. And there were many who progressed too. Interestingly, most of the patients who had a response were the high-grade carcinoma. So the response rates in the high-grade neuroendocrine carcinoma group was 44%. Compared to the low-grade tumors, it was 0%. Now, there are some issues with the study. We were all very excited that this is a patient population which might benefit from combination immunotherapy. And we looked at that, but it was a small study, 32 patients. They didn't, differentiate whether this were the NET or the NEC, as we have talked all about how these cancers are so different. Also, this was a study that was not a planned analysis. Just looking at the high grade, 44% of them responded. This was not something that they had expected initially, so it was an analysis done after the fact. Nonetheless, it doesn't decrease the value of that this treatment might be an option for patients and needs further studying. So I think they are planning to do further study to evaluate this combination in a more prospective fashion in patients with high-grade neuroendocrine carcinoma. So we're very excited about that. Unfortunately, a similar study that was done with 2 other immunotherapy drugs, which work sort of the similar way. One is called durvalumab, the other one is called tremelimumab. And what they did was they took this treatment option and they offered it to patients with neuroendocrine cancers. They're different cohort. One cohort was patients with grade 3 neuroendocrine neoplasms, and a Ki-67 score was greater than 20%. Out of them, 60% of them were the poorly differentiated high-grade neuroendocrine carcinomas. And what they wanted to see was how many percentage of patients are alive at 9 months. So when they looked at it, the response rate was not as good. How we've seen a 44% of the tumor shrinking before. With this combination, only 7% of the patients showed a shrinkage in their cancers. But it did cross their threshold of what would be defined as a reasonable 9-month survival, because 36% of the patients were alive at 9 months in this population, and they hoped that it would be greater than 25%. So that's, there was a study. One is really exciting and positive, the other one not so much, but still it warrants further investigation because it's such an area of unmet need in this disease population. There's also studies being developed to study just the small cell variant of neuroendocrine carcinomas, just extrapolating from the data from lung cancer literature, trying to combine immunotherapy with chemotherapy first line. And these are all studies that are, starting to be put together or in different phases of their development. And hopefully at someday we will be able to get the results and tell you what all of this means. So one thing I do want to talk about is there's something called MMR deficiency. There's something called Lynch syndrome, if you may have heard. But there's also a group of patients who have mismatch repair deficiency, but don't have a clinical syndrome. What this means is, in normal cells, whenever the cells are dividing, and when they divide, there are errors that happen during that process, and all of our bodies have ways to repair those damages. So this is called the mismatch repair pathway. Sometimes that pathway is abnormal, you don't have those proteins, and as a result, you tend to accumulate a lot of changes or mutations in the gene. And because of that, you develop cancers, but these cancers are explicitly sensitive to immunotherapy. So much so that pembrolizumab or Keytruda has a blanket approval for any patient who has this change, a mismatch repair deficiency or microsatellite instability or MSI high. These are just different ways we call them. Pembrolizumab has approval to be used with this genomic change for any cancer type in any patient. So it's called a tumor agnostic approval. And when you look at neuroendocrine cancers, we do see a good percentage of these patients tend to have MSI high status. And as you can see here, when you look at one study, MSI analysis was done on patients with 89 GI neuroendocrine carcinomas, and they found about 12% of them had mismatch repair deficiency or MSI high. That's a pretty high number. Similarly, there was another study of colon neuroendocrine carcinomas, and about 10% of them had high MSI. And because of these changes, I think it's important to know that since immunotherapy is very effective for these types of cancers, all patients with high-grade neuroendocrine carcinomas should be tested for this as well. It's a very simple test. They just, the biopsy sample that you get is stained for these special stains. So it's not a fancy test, but it's something that should be considered from all patients because the rate of MSI high is pretty good in this patient population. Basically, in nutshell, the role of immunotherapy is not established in G3 neuroendocrine neoplasms, but the results are promising and it needs further evaluation. And it can be used in a case-by-case basis, and sometimes our guidelines do talk about it. So how can we improve the climate, in the current condition? So as you can see here, we have a lot of things we can do to make things better. Some things that we have looked at our center is to look for mutations or molecular changes that can guide therapy, right? Is there a molecular change in your tumor that I can find a drug against that's not chemo, it's not a cookie cutter approach, but I can just treat your cancer with the type of change you have. And that's an area of interest for all types of cancers. So when we looked at neuroendocrine tumors, what we did find was that the low-grade tumors don't have a lot of mutations. As you can see here, no mutation, the light pink and the red lines, not a whole lot of mutations in the GI neuroendocrine tumors and the pancreatic neuroendocrine tumors. But if you look at other mutations, the blue line indicates all the mutations that are seen in the high-grade, poorly differentiated neuroendocrine carcinomas. So that's an important thing to remember, that there are mutations that are seen in this population, and it may be beneficial to do molecular profiling to identify new targets. So in our study, what we did find was about 13% of the patient had a BRAF mutation. There is a drug against BRAF mutation, and actually one of my patients went onto a drug for it. About 22% of the patient have a change in the PTEN or the PIK3CA pathway, which is targetable. There's about 30% of the patient have KRAS mutations, and some KRAS mutations are targetable, now in the current day and age. It's still investigational, but there are things we can do or studies that we can put patients on So genomic profiling is it's something to be considered for these patients too, especially because we don't have a lot of treatment options. Then we also looked at, so we looked at the gene. Now, we looked at the gene, we also wanted to look at the signal that the gene gives to make the protein, which is the next step. And that's called the transcriptomic analysis. And what we found when we compared the poorly differentiated tumors and the well differentiated tumors, there are some genes that are highly expressed in patients with poorly differentiated cancers compared to the well differentiated cancers. As you can see, this gene called EZH2, CHEK1, and then PAC3 in the well differentiated and STAT3 in the well differentiated cancers. So these are just examples of what we are looking for. These are some pathway analysis that we have done, which have identified the ways by which these cancers might be growing, because each of these pathways may have drugs that we can use against. For example, the DNA repair pathway has very specific drugs, olaparib or PARP inhibitor. There are some newer drugs that are coming in, or platinum-based chemotherapy are especially beneficial. So all of these things we are finding and learning more and more about these poorly differentiated or G3 cancers. And as time moves on, we'll identify new targets for these patients. And so for final words, I just want to say that these are a rare subtype of a very rare cancer. That doesn't mean that it's not there. We see patients, the more we look for it, the more we find. It needs special attention, and their treatment paradigms are different and very nuanced, and that you probably should seek opinion of a specialist in this area. It's an area of unmet need in terms of treatment options, not a whole lot of prospective studies, but we want to do them. And we want support from patients to go on to these studies so that we can identify what's the best way to treat our patients. And then there's novel agents and immunotherapies that are being investigated and explored, so the future definitely appears bright. So thank you so much for having me. I really appreciate the time, and I think we're going to go for the Q&A session next. So appreciate your time. Thank you.
Welcome everyone to this live Q&A. We're really excited to have you all today, and we're excited to have our special guest, Dr. Vijayvergia, and she's given me the permission to call her Dr. Vijay during this Q&A portion. Just a reminder for everyone watching at home, this is for educational purposes only and is not a substitute for medical advice, but we invite you to ask your questions, and you can still submit your questions via Slido with the event code LACNETS if you have not already done so. So Dr. Vijay, welcome, and thank you for that very thorough and helpful presentation with a lot of information, lots of hope and promise, and we're really excited to have this opportunity to ask you some questions.
Yeah, thank you so much, Lisa. Thank you very much for inviting me to give this talk. And I think neuroendocrine tumors are rare, high grades are even rarer, and somehow happen to be my passion. So I'm really grateful for the opportunity to present too.
Great. Yeah, this is really helpful. So we're going to start with the first question today, which is, if tumors do not have somatostatin receptors, will they ever? And I thought this was one of the most helpful slides that I saw, was the question you had about continuum. And that question comes up a lot. Do differentiation and Ki67 change? And so this is kind of, on that spectrum of tumors changing in general. So one question in that realm is, if tumors do not have the receptors, will they change?
So that's a great question, and I think that is something that we have been looking into as well and trying to figure out. Typically, what happens is, most of the time, the progression of disease happens from a more differentiated version to a de-differentiated version, which just means that it becomes I have seen cases where patients had the receptor before, and then as the disease progressed, the receptor was lost. So it became a little more undifferentiated. The only time I've seen, so sometimes what happens was the patient got a octreotide scan before, which was the older version of it, if you guys remember, and the newer net spot scans, or the copper dotted tox scans, are much more sensitive. So sometimes patients had a negative octreotide scan, and then we do the net spot scan or the gallium-68 scan, and that becomes positive. So that's one time that I've seen. It's just a different test. And sometimes the tumors are very, very tiny. So we see multiple tumors, but all of their sizes are less than like a centimeter, 6 millimeter, 8 millimeters. And at that time, it might be below the threshold of identifying at the for your somatostatin receptor imaging or the test that you do. But in general, if you have a net spot scan and you have bigger tumors that do not have the receptor, the chances of them developing receptor down the line is probably next to 0.
Okay, that's helpful to know. So while the larger tumors may not change in going from lacking receptors to having receptors, maybe it's an issue with scanning, and the scans may not yet pick up the receptors. Okay.
Exactly. So
Okay,
that's
great.
why the tiny tumors, it's important to repeat one when
Or
they're bigger.
Or if people got the older, antiquated octreotide scan. Yeah.
Absolutely.
Okay.
Because you believe it or not, there's a lot of insurances that still require us to do those scans. So, sometimes you just have to twist their arms.
I guess on a related note, would the copper 64 scan make any difference in terms of picking up receptors?
No, and there's pretty much no difference between the sensitivity of the gallium dotatate or the copper dotatate scan in general.
Great,
I would
thank you.
probably use them interchangeably.
You would use them interchangeably. Okay, great. So one thing that you mentioned that was also really interesting in your presentation was the discrepancies in a pathologist's read of the same specimen. Would you recommend getting a second opinion to confirm grade indifferentiation?
Absolutely. I think that is so very important, at least for, I cannot tell you how many times it happens that it has been called by an outside pathology report to be a low grade, and we see and it's a higher grade, or it was called the G3 neuroendocrine cancer and it was actually a well-dev G3. So a second opinion from a pathologist who's actually really good at reading neuroendocrine tumor scans, or sorry, neuroendocrine tumor slides, is critical in my opinion, and should be done for all patients.
Thank you. That's helpful. So along the lines of workup, and especially for these G3s, when do you order that FDG PET scan? So again, you highlighted both the gallium dotatate scan and the FDG PET scan in this population. When do you order it? Do you order it for both the well-differentiated and poorly differentiated? And if you do order it, how often do you order it?
So great question. I think we were at the NCCN guideline call the other day, and we were all debating amongst ourselves which one should we order and when should we request. So there's a lot of discrepancies amongst providers as to how they order it too. My personal practice is that I typically don't like to order the FDG PET scan, so the run-of-the-mill PET scan that you do for other types of cancers for most neuroendocrine patients. So even if I'm a grade 3 neuroendocrine, if I just do CAT scans, you have disease, you know where the extent of the disease is. Now I can do a gallium PET scan, which I tend to do especially for the well-differentiated group. That tells me two things. One, it confirms that these are well-differentiated. And second, it actually tells me that PRRT may be an option for these patients. So I'm doing the test, it's given me very, very important information. Now, when I am about to do PRRT for somebody, I like to also do a FDG PET scan just to make sure that there are not some other areas that I'm like not seeing on the gallium scan, because there's discordance. Now, that information you actually can get from your CAT scan too. So you have a good quality CAT scan, you have a good quality radiologist. They can basically see which of all the lesions you see on the CAT scan light up on your gallium PET scan. If all of them do light up on the gallium PET scan, PRRT is a great option. Again, there is no need to do a FDG PET in this situation. An FDG PET, I think, is mainly overused in my opinion. I don't think it gives me a lot of information. Yes, if the FDG PET is positive, you tend to know that the outcomes are going to be slightly worse. They're more aggressive. That's why the FDG PET is positive. But I think if you have a good pathology, good CT scan, and the gallium PET scan, you can easily deduce that information too.
Great, thanks. That's helpful. You use the word discordance, and there might be people who are watching who don't understand what that word is. If you could explain that, that would be helpful.
Thank you. I apologize. I should have thought of that. So basically, what we're trying to do, let's say for grade 3 neuroendocrine patients who are NET types, so who are the well-differentiated ones, and you want to treat them with PRRT. So PRRT is only going to go and work on the tumors that express the somatostatin receptor. So they light up on the gallium PET scan, all those tumors will get the drug and get benefit from treatment. Now, sometimes what happens is some tumors in a patient express the gallium dotatate, the somatostatin receptor, which light up on the gallium scan, but some tumors do not. So there's a discordance. So when you do a gallium scan and when you do a CT, you see 10 lesions on the CAT scan, but only 5 on the gallium scan. Or you do a FDG scan and a gallium scan, and you see 10 light up on the gallium and 20 light up on the FDG. So you know that there is some difference between the two. So there's discordance between the two scans, really just the literal word meaning. And what it suggests is that maybe if you only treat with PRRT, you're probably not treating the entire problem and only a part of it. So it's an important information to help us decide if PRRT is the best next option for a patient.
Right. And I think that that's really a helpful thing to know. So since you brought up this idea of discordance and it affecting your decision with PRT, how would then having discordance or having, even if it's not discordant, if you just had uptake on both and they were equal, how would that affect your decision to move forward or not to use PRT?
So
and the timing of it.
It's yeah. So it is a very that's a very scientific question that needs to be answered by us at this time. So there are some retrospective studies, as in they just patients were treated and they went back and saw how they did, and some of those studies suggest that if you have activity seen on the FDG PET scan, you tend to do worse if you do PRRT. But in general, if you have activity on the FDG PET scan, you tend to do slightly worse than if you didn't have activity. So we do not know if it actually tells you if the effectiveness of the PRRT is affected by FDG PET scan. So it needs just some more testing, in my opinion, to know one way or the other. I just do know that if you have 5 lesions that are positive on the gallium scan and about 20 lesions on the FDG PET scan, you really know that just treating those 5 is not going to make a big difference in how this patient's going to do in the long term, right? So in that case, PRRT may not be the best option. Compared to it, if if the gallium scan lights up in all the tumors, I think PRRT is still considered, and we still yet have to know if how much activity we see on the FDG PET scan, if that somehow affects how you're going to respond to PRRT. I think it's still a little in question, in my opinion.
Mm-hmm. Yeah, thank you for that. That's really helpful.
I know it's very
Dr.
confusing.
Yeah, I think that's helpful because sometimes it's not discussed very much about how that might influence the decision. So this question came up that I thought was interesting too. Out of all neuroendocrine patients, how do they break down by percentages in terms of grade 1, 2, and 3? Are most patients grade 1?
So I think about 15% of all, I know more about the GI neuroendocrines because that's what I do for the most part, but in about 15% of all neuroendocrine tumors are the grade 3s. So 85% of the neuroendocrine tumors are grade 1 and grade 2, and out of which grade 1 actually still form about 50% of them. So even though the Ki67 is 0 to 3 versus the grade 2, which is 3 to 20, there's actually more patients in the grade 1 than there are in the grade 2. And it varies from where the location is. So if you just look at the intestines, 90% of them are grade 1. If you're looking at pancreas, you can see about a smatter of grade 1, 2s, and 3s. If you're looking at lung, you have much higher incidence of the grade 2s and the 3s.
Okay, thank you for that. Another question that came up that have to do with the workup or surveillance is what biomarkers might you order for surveillance in G3, NETs, and NEC?
Yeah, I think that is a good question, but I think probably no one knows the answer to that question. There is no proven biomarker at this stage. No blood test can tell you. Only CAT scans and some sort of imaging is the gold standard to follow patients. Patients, we do chromogranin, and I can tell you I recently read read a study where they checked chromogranin levels for normal people who didn't have neuroendocrine tumors and also for patients who had neuroendocrine tumors, so half and half. And they found that the average level of that hormone was actually higher in patients who are non-neuroendocrine. So in normal people, the level of chromogranin was actually higher than patients who had neuroendocrine tumors. So all it just tells us is it's a very insensitive marker. And sometimes its number going up can actually just cause more angst than any benefit. So I really feel that just a regimented scanning and making sure you follow symptoms and patients' a physical exam and a history are way better than any kind of biomarker test. It's just more expensive and doesn't really help us much.
Yeah, so you're saying not to put a lot of meaning into one particular
No,
biomarker
absolutely
or any
not.
testing.
There is none.
Okay.
There is no biomarker that will tell us that yes or no answer.
Okay. I like what you said too, that it might just cause more angst. And so it's important,
It does.
I guess, to look.
And not only to the patient, it actually causes more angst to physicians too, because, we are also seeing that number. And then I'm doing 20,000 tests for it because I see a number. It's hard to ignore it.
Yeah. Okay. So we want to do more than treat the numbers. And speaking of other testing, you mentioned the MMR deficiency and testing for MSI. So can you kind of go back and explain what MSI, MMR, all these letters mean, and how this testing's done?
Absolutely. I think this is an important point to be made. So what happens is when, normally this is a test that they do on your tumor. So whenever somebody has a biopsy, you get tumor tissue and you can test for something called MSI or MMR. And what they do is they special stain, they look for some special proteins that define it. And if you are lacking in any one of those proteins, then you are deficient. The reason why this is important is because of deficiency of any of these proteins is a direct biomarker that immunotherapy is going to work for these cancers. And so much so that actually pembrolizumab or a PD-1 inhibitor has a tumor agnostic approval. So basically, no matter what kind of cancer you have, if you have an advanced cancer and if you have deficiency of one of these proteins, your insurance should cover pembrolizumab for you because we know it works in that situation. So this is the reason we should test for it. Previously, neuroendocrines, people weren't even doing molecular testing, but now that we are doing a little bit more, we found out that the incidence of this protein being deficient is even up to 10%, which is a pretty high number in patients with especially with the colonic or GI neuroendocrine tumors. So that is something to keep in mind because then immunotherapy is definitely going to work for you, hopefully, like 80% chance.
That's helpful, Dr. Vijay. And how would patients make sure that they're tested for this?
So I think just talking to your physician, this is sometimes, we all have to be our own advocates at some point in time. This is a rare cancer and not everyone may know what to do. Just talking to your physician that can you test for MSI? Can you test for MMR? They're both the same thing. It's a different kind of test. And I don't think you need to get into the details because everybody knows about, like all oncologists know about this test because it's routinely done for colon cancer. So for colon cancer, there's a genetic syndrome Lynch, and everybody knows about doing this test for colon cancer, for uterine cancer, but nobody knows to do this test outside into neuroendocrine world. So that's why it's important. You just tell them, can you please order that? And they will do it. And in general, I think, expanding on the same idea, right? Not just MSI, there's a lot of new targets that are coming up. NTRK, there's a tumor mutation burden or TMB. These are all molecular changes that are that we can see in tumors, in neuroendocrine cancers too. And if you have one of these changes, there are drugs that are approved out there for you. So you have to, all advanced patients should advocate for trying to get their tumors sent out from deeper molecular testing if possible.
You read my mind because that was actually the next question, how patients get their tumors tested for mutations. So what should they be asking for? Do they go in and say, Dr. Vijay, how do I get my tumors tested for mutations? What's the wording?
Absolutely. So I think in patients with advanced disease, so typically molecular profiling is not something that we do for patients that is early stage. So if you had surgery and the cancer is out, typically we don't do molecular profiling in that situation. Insurances don't cover it, and there's no usefulness, in my opinion. But in patients with advanced disease or that's incurable, all the treatment options we have at some point run out. So you have to come up with novel things to treat patients with. And all patients at advanced stage should be tested for molecular mutations. We have done our study. There's BRAF mutation. There are drugs against it that are very effective. People have done that. For example, in lung cancer, right? There's EGFR, ALK. These are some genetic changes you see, and there are pills against them. And the same way for high-grade neuroendocrine cancers. If you can find treatments that are not chemo, that's a win. That's a great thing. So all patients with advanced disease should be discussing mutational profiling. That's how we call it. How do we do a mutation profile of my tumor? And your doctor can send it out, because the good part is at this point in there's third-party vendors who do it across the country, so it's very easy to send out. Then a lot of places have their own platforms on which they run it, just like ours. But you don't have to be at a higher center to do it. Your oncologist can take care of that for you.
Okay, that's helpful, Dr. Vijay. And so if a patient is asking for a mutational profiling, do they need to get re-biopsied if they don't, or if they already had one? Or you mentioned tumor tissue, so talk a little bit about that.
Yeah, absolutely. So I think that is a very good question. It is in an ideal scenario, if biopsies was as easy as just looking at somebody, I would say patients should get a biopsy and a mutational profile every time they progress on a treatment, because we know that with treatment, as the disease progresses, you tend to accumulate new mutations. Okay, but that's not possible. We're not guinea pigs, and you cannot do that for everybody. So I typically, talk about and recommend, if you have a tumor tissue for advanced disease, that's like from a metastatic site, if you already have it at the time of diagnosis, I tend not to repeat the testing. Sometimes what I do is we know some of the molecular markers, like, if you have a mutation and you treat with a drug against it, sometimes we know how you become resistant to it. So you want to look for that specific change. And in that scenario, we do something called liquid biopsies, in which what they do is they get a sample of your blood and look for the cancer-specific DNA or cancer-specific genes in your blood sample itself. And then we can use that and compare that to your prior tissue, so that we spare you from getting biopsies left, right, and center.
Great. So liquid biopsy is another thing we can ask for. Okay, another question just popped up about what you meant by work, and I believe that that's related to what you were talking about, if there's any mutations or MSI instability, that certain things may work. So if you could explain what you meant by certain treatments working or not.
Absolutely. I think by work, I mainly mean is that it's effective in controlling the cancer, may cause shrinkage, and improves your lifespan or improves the survival with this disease. So if you have a mismatch repair deficiency, if you have the MSI high, giving pembrolizumab has shown to improve the lifespan of people, has shown the cancers to shrink, and that's why we recommend it. That's why FDA has approved it for that scenario. Similarly, if you have a BRAF mutation, there is a drug called vemurafenib. There's a combination of two drugs together, cetuximab plus vemurafenib. These are just fancy novel therapies that are targeted against these changes, and these might help to control the cancer and prevent it from growing for a certain duration of time. Unfortunately, the cancer is sometimes smarter than we are, and while we're treating one way by which this cancer is growing, it actually may find another way to start growing. So we have to keep a close eye, and we don't think that we can identify one thing that will just basically shut the cancer off completely. But it might give us some time, and then in that meantime, something new will come up, and we can try that.
Great, thanks. That's helpful. There's several questions about treatments, and I think a general one we could start with is, what treatment options are you seeing specifically for those G3s without somatostatin receptors?
So I think that is something that we have to look for in the G3, because a ton of them don't have the somatostatin receptors, especially the neuroendocrine carcinomas. I think immunotherapies or immunomodulatory drugs is probably the most exciting thing on the horizon. There's also, we're looking at new receptors. So, tracking antibody drug conjugates is what it's called. So basically you have the chemotherapy or a drug that goes and kills the cell, and you attach it to antibody that goes and attaches to these tumors. We are looking for new markers or new things on the tumors that it just goes and attaches to. So there's a drug targeting the DLL3 pathway and things like that. There's also a lot of talk about, immunotherapy combinations, oncolytic viruses, is something that is being looked into. CAR T cell therapy is something that is being studied for neuroendocrine tumors and cancers, which is not dependent on somatostatin receptors, or they don't have the there's also drugs for somatostatin receptors, but these are all therapies that are out there which are not for it. So I think all of these things are very exciting and something to look forward to.
Okay. And the next question is related to something you mentioned, which is the status of oncolytic virus trials. Does it show promise? And what's your opinion about oncolytic viruses, specifically for G3Ns?
I think oncolytic viruses have been in testing for some time now. We're trying, the only one that's actually approved so far is the TVEC, right? So there's a oncolytic virus TVEC that is approved for some types of cancers. But in neuroendocrine, they're looking at a multitude of oncolytic viruses. For those of you who don't know how these work, it basically is a viral, like a modified viral that you give to, inject into the tumor or give it to the patients, and then it sort of goes and attaches to the tumors. It is specific to the tumors in some way, and then basically directly kills the cancer cells. So it's oncolytic. And also it stimulates your immune system. So not only does it kill the cancer, but it stimulates your immune system to kill the cancer on the sideline too. So it's a very exciting way to look at things. It might be, seems to be less toxic. It's better safety profile. Trying to find that specific oncolytic virus that actually kills the cancer cells, doesn't harm your normal cells, and is not negated by your own body system is a work in progress. I have to say that I would love to tell you that it's ready for prime time. It definitely is exciting. There's multitude of different things. There's one oncolytic virus, the SVV or Seneca virus, Valley virus vaccine. There's one looking at the survivin protein, which is being developed by Dr. Iyer at Roswell Park. But there's a lot of different things that are being looked into. None of them are ready for prime time, but they definitely look exciting.
Okay, that's helpful, and that sounds exciting.
Yeah, and these are all specific for neuroendocrine.
Yeah, that's great. It's great that there's options out there on the horizon. So something related is, will the COVID-19 vaccine have any impact on these immunotherapy drugs?
I don't think it will, though. I really don't. I think this is a lot of, we give patients live viral vaccines a lot of times, right? You give patients vaccines for shingles and stuff, which are live virus vaccines. And it's basically stimulating your own immune system to form antibodies or form efficacy, so the T cells, give your immune cells the ability to fight the infection. I doubt it will actually have any effect on on immunotherapy affecting your cancer, but who's to tell? I think we still have there are specific trials going on in cancer patients with these drugs. What I really feel is that because if you are on chemotherapies or other cancer-directed therapies, the chances of you responding to the vaccine may be slightly lower because your immune system is a little suppressed. But I don't see any major problems. But really, time will only tell us.
Yep, time will tell. We have time right now. Did I cut you off? Were you going to say something else before I started reading this question?
I was, but I've forgotten, so it'll come back to me.
Okay. Here's another question that came up. So this may be a little case specific, but the general idea is if you've already exhausted several of these options, Captem, cisplatin, etoposide, immunotherapy, FOLFIRINOX, FOLFAX, radiation, Y90 radioembolization, what else might there be for G3-NENs?
So I think, as I said, right, G3-NEN should be literally two different cancers, the G3-NETs, which are the well-differentiated, and the NECs, which are the carcinomas. So if we're talking, I think if you're talking about the NETs or the G3 well-differentiated neuroendocrine tumors, those patients actually do respond to some degree to a lot of the treatments we use for grade 1 and grade 2. So everolimus is something that works, that I have used personally. Sunitinib maybe, but mostly everolimus it's a system, it's a pill, Afinitor, which is used for grade 1, grade 2 tumors. That's really does work in the grade 3 NET population. And for the G3 neuroendocrine carcinomas, Unfortunately, it's literally you have exhausted all the options that are out there. But that doesn't mean, you, as I just told you, molecular profiling to identify new drugs. We typically find clinical trials for our patients all the time. Like I literally have 3 patients right now in a clinical trial. So, these are the perfect timing to do a clinical trial. And there are, fortunately, clinical trials specific to we have like 2 high-grade neuroendocrine clinical trials at our center right now. They're early phase. They're not like, oh, they're like ready for prime time, but at least they have cohorts that people are looking at this cancer. So I have to say, I remember what I wanted to say. I think it's from the effort of groups like LACNETS and others and patients that people are actually, more cognizant of this disease, that they are actually developing therapies for this disease, like specifically, which wasn't the case until like maybe even 5 years ago.
Thank you for saying that. And it's certainly a team effort. We're stronger together. So along the lines about clinical trials that you mentioned, how would you advise patients to find out about open or upcoming clinical trials that might be suitable for them?
Yeah. So I think, talk to your doctor. That's the first thing I always say, because you are your own advocate, but your doctor is your second best advocate for you. Apart from it, if you want to look it yourself up, the clinicaltrials.gov website is very helpful. You literally have to type neuroendocrine carcinoma in there, and you point out the area that you're in. Like, it just gives you it will bring up all the studies that are there. Once you get a printout, you just get a printout and take it to your doctor, instead of trying to tease out which of these actually you will qualify for, which you will not. I do it all the time for my patients. I don't have all the studies. Some are present at other institutions. My patients bring it up, and then we go through them and say, hey, out of all of these, I think this specific one makes the most sense. So it's hard for you to know about all these new things. It's hard for oncologists to know about all these new things, frankly, because there's so many new things coming up. But I think if you actually, share the burden, it would be much easier for you.
And can I ask you, this is not on this question, but if you weren't running a clinical trial, but say one of your friends are a couple states away, is that something that you could, even if that patient couldn't travel, maybe you could get on the phone and talk to them and ask them about the early results or anything like that to work collaboratively?
Yeah, we do it all the time. So we have in our area, we have like the Northeast Regional like clinical trial list that we call it. And what it is basically New York, Philadelphia, Baltimore, Maryland, and DC, and NIH. All of us, the investigators, we all have like a common shared email. And we have any patient that we want to put on a study, we just say, hey, this is like the extent my patient will go to and can travel easily. And so, hey, do you have any studies? It's like, yes. Is it look promising for my patient? And then we talk about it and look up, and then I ask the patient if they want to go. So many times I've sent patients down to Hopkins or patients down to NIH. I've treated patients from New York because, when COVID happened, they just shut down their clinical trial portfolio. So I had so many patients come down from there. So we just do it all the time.
That's really encouraging to hear about the collaboration that's going on amongst you. Thank you for that, Dr. Vijay. And I guess a general Go ahead.
I was just saying, and do not feel that your doctor is in any way, shape, or form intimidated by the providers in the area. Our common goal is to make you feel better. If I can assist you in any way to do that, I consider myself fortunate, and I'm pretty sure everyone in the medical field feels the same way. So please do not, getting second opinions, getting anything, all of these things are something that we encourage. We really do feel that, we are also humans, right? At the end of the day, if someone just tells me whatever I'm doing is right, it just makes me feel better about the fact. If I'm not doing it right, I actually want to know about it so I can actually get better at it. So please, please, please do so. Talk to your doctor, talk to them about whatever you want to do, and for collaborating with other centers.
That attitude
I can
of
give you an example. Yeah, I can give an example. I had a patient who wanted to get a second opinion at another center. I'm not going to name it for the sake of privacy, but they wanted to get it, and one of the patients didn't tell me about it. And then they actually, called the number there, and they made an appointment with the doctor who doesn't even see neuroendocrine tumors at that institution. It's like whatever's next available, they just put them on, and then that wasn't helpful. Compared to it, there was another patient who asked me. I actually emailed the neuroendocrine tumor expert at that place, say, hey, and that person basically facilitated the appointment so the patient got to see them, got to see the right person, and the doctor there was able to get back to me and tell me what their opinion was and how we wanted to do it. And the same happens the other way. Like I think when physicians just call me that patient's going to be treated, they give me a heads up, and I think it just makes it so much better.
Yeah, that openness to collaboration is really encouraging, and it eases the anxiety on the patient end. So if we could just do a couple more questions. I guess in general, what kind of guiding principles or advice do you have about making treatment decisions and sequencing the treatments? How do you go about this, and what advice do you have?
I think the biggest guiding principle is how symptomatic the patient is. I think that is my backbone. Like the first question I ask my fellow when he goes into a patient's room and comes out has grades, is like, all right, how is the patient feeling? If the patient is symptomatic from their disease, if their labs in some way, shape, you have to start with treatment right away. You have to start with chemotherapy because that's the one that works the fastest. If this is all for G3 patients, right? If on the other hand, if the patient's feeling okay, you have time and you can look at all the different options for treatments. I feel all the different treatment options that we've talked about, they all have a place. There's no right answer for which one should be first and which one should be second. We really don't know, because I think all of them have a place, but for a different patient. So I think I have G3 patients who some of them I have on just somatostatin analog. The other one I start on a carboplatin. The one I started in somatostatin analog, third or fourth line, has moved on to platinum etoposide too. So I think it is all of these treatments we use, and what guides me is mainly how symptomatic my patient is and how quickly I want a response.
That's really
it's a
helpful.
marathon, not a sprint, right? We have to use all the options and use them wisely. If I can, I want to start with the one which is least toxic, most effective first, and then move from there.
Okay, so least toxic, most effective, and then going by how they feel, because it's about quality of life, and I know you care about that. Okay, well, I think the last question is just in general, what is one major takeaway you'd like to leave the NET community with today?
I think so more than one, a few. First, I want to really, really thank you all. I think it is your effort and your advocating for yourself that has made neuroendocrine tumor research come to limelight, and people like researchers are interested in it, but not just people who are treating. So thank you for doing that, and I really appreciate that. Second thing is, I think with all these different treatment options that are out there, we have hope. Yes, I had a cure in my hand. I don't, but even small advances can just make a huge difference if they're all put together. And the third is, I really want to make sure that whenever you get diagnosed a G3 patient, should at some point get an opinion with someone who's very well versed with treating neuroendocrine neoplasms, for pathology review, to make sure, just to get a second set of eyes on the whole matter from someone who's more expert, or who's just following the field more closely, as I would say, is something that everyone should consider.
Thank you, Dr. Vijay. You've given us so much to think about, a lot of pearls as well, a lot of wisdom and insights. And I really want to thank you for your time and you coming to educate us all today. And there's just encouragement, right? The openness to collaboration, the excitement about what's out there in the field, and this collaboration, not just among doctors, but with the patient community as well. So thank you for all of that. So as we close the Q&A, did you want to say something?
I say thank you so much for having me.
Thank you. As we close the Q&A, I just want to remind the audience that you'll be receiving a survey after the webinar, so we ask you to please fill it out. It helps us to know what you liked and didn't like. And we are also sending out a different, very important survey called the LACNETS Needs Assessment Survey that helps us plan for 2021. So if you have not already filled it out, please take a few minutes to do so, because they are very important for our planning purposes, and they also help us support the programs. They matter to us and our supporters and donors as well. So thank you in advance for filling them out. And now this concludes our Q&A. Thank you again, Dr. Vijay, and I'll let you take it away, Rich. Back to you in the studio. Thank you, Dr. Vijayvergia and NET patient Cindy. We appreciate the opportunity to learn from you more about high-grade NETs. 2020 has already been quite the year, and we're excited to announce the next 2 upcoming educational webinars. Our December speaker is Chaplain Michael Echelon, board-certified chaplain of the UCLA Center for Integrative Oncology Sims Mann Center. His presentation is Stringing the Beads of Our Own Story. He is a TED Talk speaker, and I'm always encouraged and inspired to hear his stories. So please join us for the next meeting in December on Tuesday, December 8th at 12 noon Pacific Time. We're excited to announce our first 2021 live webinar by author and professional speaker Kim Hammer. Her presentation, How to Ask for, Accept, and Get the Help You Need, is helpful for patients and caregivers alike. Whether you're someone living with cancer or you know someone living with cancer and you would like to help them, this is the webinar for you. Please go to our website to learn more about our other programs. We have many opportunities to connect with other patients and get the support you need, including our virtual weekly NET support groups, our monthly virtual NET caregiver support groups, our NET Vitals, which is a patient-physician communication tool, and free health coaching available to NET patients and caregivers alike. You can find this information on our website. And now back to you, Lindsay.
Thanks, Lisa. As a reminder, be sure you're following LACNETS on social media to stay up to date on upcoming webinars and NET news. As a reminder, today's webinar is being recorded and can be viewed on our YouTube channel shortly after the live broadcast. Thank you to everyone who tuned in live today. We hope you were able to have your questions answered. Thank you again to Rich at TVP Live for this high-quality webinar production. We hope to see you at our next webinar on December 8th. Goodbye, everyone.